Welcome to HTL 308 Hematology. This course connects cell morphology, hemostasis physiology, and laboratory interpretation. We will explore how visual clues under the microscope link to underlying biological processes and clinical conditions. Our goal is to build a way of thinking that bridges textbook knowledge with practical laboratory reasoning. We'll ask 3 questions. What does it look like? What process produced it? And what clinical problem does it explain? This approach will help you interpret findings and understand why certain tests are ordered. It's about connecting the dots between what you see and what it means for patient care. Today, we're mapping out our journey through hematology, moving from what we see to what it means. We'll start with red blood cells, as their changes often provide the first visual clues to disease. Then, we'll move into white cell and platelet production, understanding how these cells develop in the bone marrow. The second half of the lecture focuses on hemostasis, which is a coordinated sequence involving vessels, platelets, and clotting factors. Finally, we'll connect all this physiology to laboratory testing. The overall theme is correlation. Morphology, mechanism, and laboratory interpretation should always reinforce one another. Normal red blood cells are our baseline for recognizing almost every abnormality. These anucleate biconcave discs are optimized for gas exchange and deformability. On a well-prepared smear, they have a central pallor about 1/3 of their diameter, reflecting their biconcave shape and hemoglobin distribution. When these cells become smaller, larger, paler, or irregularly shaped, it usually points to problems with hemoglobin production, membrane structure, or marrow production. Just like tissue sections reveal architecture, a blood smear reveals cellular architecture. So, a normal field should show consistent size, appropriate staining, and minimal abnormal shapes. Any disruption to these baseline features gives us a map of the underlying process. Now, let's see how we quantify these visual observations. While the peripheral smear gives us visual information, RBC indices help quantify what we're seeing. The MCV, or mean cell volume, tells us the average red cell size, which is crucial for classifying anemias. MCH and MCHC reflect hemoglobin content and concentration, helping explain hypochromia. RDW, or red cell distribution width, estimates variation in cell size, which is useful when multiple processes are occurring. And the respiratory count asks a functional question: is the marrow responding appropriately to anemia? Combining these analyzer reports with smear confirmation gives us the strongest hematology interpretation. Next, we'll dive into what microcytosis usually indicates. Microcytosis means red cells are smaller than expected, and this usually points to trouble with hemoglobin production. Hemoglobin synthesis relies on iron, globin chains, and heme. When any of these are limited, red cells often undergo extra divisions in the marrow, becoming smaller and often paler. Iron deficiency is a common cause, but it's not the only one. Thalassemias, which are globin synthesis disorders, can also cause marked microcytosis. Anemia of chronic inflammation can also lead to microcytosis because iron is present, but less available for erythropoiesis. On the smear, look for accompanying hypochromia, anisocytosis, or target cells, and then compare these findings with indices, iron studies, and clinical context. Microcytosis is a clue, not a final diagnosis. Now, let's look at how iron deficiency progresses. Iron deficiency is a common cause of microcytic anemia, but it is not a static condition. It unfolds in stages, and we can see that progression in the lab results. Early on, iron stores decline, which you might pick up with a ferritin test, even before the red cells look dramatically different. As iron becomes truly limited, the marrow starts making smaller, paler cells. Because older, normal cells are still circulating, the RDW often increases, showing a mix of cell sizes. Over time, the smear shows more obvious hypochromic microcytes, and sometimes even pencil cells. This visible change reflects a structural problem. The red cells are underfilled with hemoglobin because the raw material, iron, is insufficient. Next, we'll look at another cause of microcytosis, thalassemia, and see how its mechanism differs. While iron deficiency is about iron availability, thalassemia is about globin chain production. This genetic defect leads to globin chain imbalance and ineffective erythropoiesis. On the smear, you'll see marked microcytosis and hypochromia, often with target cells. But here's the key difference from iron deficiency. The red blood cell count might be relatively preserved, even increased, despite the very small cells. We call this disproportionate microcytosis. It's a critical distinction because giving iron to a patient with thalassemia, unless they also have iron deficiency, is not appropriate. This is a great example of how morphology guides further testing and helps us avoid misdiagnosis. Now, let's shift our focus from small cells to large cells and what they tell us. Macrocytosis means the red cells are larger than normal, and this usually points to a problem with maturation. In conditions like vitamin B12 or folate deficiency, DNA synthesis is impaired. This delays nuclear maturation while the cytoplasm continues to develop, leading to large, often oval-shaped red cells. But not all macrocytosis is the same. You can also see round macrocytes in liver disease, alcoholism, or hypothyroidism. And remember, reticulocytes are larger than mature red cells, so a brisk marrow response to blood loss or hemolysis can also raise the MCV. The key is to look at the whole picture: the cell shape, the respiratory count, and other clues like hypersegmented neutrophils. This helps us differentiate between different causes of large red cells. Let's dive deeper into megaloblastic anemia, where nuclear delay is the central issue. Megaloblastic anemia is a classic example of a maturation disorder, where the marrow is active but the product is defective. The core problem is impaired DNA synthesis, which causes nuclear cytoplasmic asynchrony. The nucleus matures slowly, while the cytoplasm continues to grow and hemoglobinize. In the bone marrow, you'll see large, abnormal precursors, and the marrow can even be hypercellular. But much of this production is ineffective, meaning cells die before they even reach circulation. In the peripheral blood, this can lead to macrocytic anemia, a low respiratory response, and sometimes even low white cells and platelets. You'll often see oval macrocytes and, importantly, hypersegmented neutrophils. Vitamin B12 deficiency can also cause neurologic findings, so accurate diagnosis is crucial. This is a powerful illustration of how a defect in DNA synthesis impacts the entire maturation process. Now, let's move on to how changes in cell shape can provide important diagnostic clues. Poikilocytosis, or increased variation in red cell shape, is a really useful visual clue on a smear. The specific shape often points us toward a mechanism. Spherocytes, for example, are dense, round cells without central pallor. They suggest membrane loss, which can happen in hereditary spherocytosis or immune hemolysis. Schistocytes are red cell fragments, indicating mechanical damage as cells pass through abnormal vessels or fibrin strands. Target cells, with their central and peripheral hemoglobinization, reflect altered surface-to-volume relationships seen in liver disease or thalassemia. The goal here is to move beyond just naming the shape. We want to understand why that shape formed. If you can explain the mechanism behind the shape, you're much better equipped to interpret it correctly in a clinical context. Next, we'll focus specifically on schistocytes and their clinical significance. Schistocytes deserve special attention because their recognition can carry urgent clinical significance. They are fragmented red cells, often appearing as helmet cells, triangular fragments, or irregular pieces. Mechanistically, they form when red cells are physically sheared or cut as they move through abnormal circulation. This can occur in microangiopathic hemolytic anemia, disseminated intravascular coagulation, thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, severe burns, malignant hypertension, or with mechanical heart valves. For laboratory personnel, the responsibility is not to diagnose the entire syndrome from the smear alone, but to recognize that significant fragmentation is not a benign finding. It should be correlated with platelet count, hemoglobin, LDH, bilirubin, haptoglobin, coagulation studies, renal markers, and clinical presentation. Smear quality matters because artifacts at the feathered edge or damaged areas of a slide can mimic fragments. When schistocytes are truly present, especially with thrombocytopenia and anemia, communication may need to be timely. This is hematology at its most practical, A microscopic observation can influence the speed of clinical response. Now, let's look at what other small clues the red cells can offer. Red cell inclusions are small, but they tell an important story about cell development, splenic function, and cellular injury. Howell-Jolly bodies are nuclear DNA remnants that normally would be removed by the spleen, so they are classically associated with asplenia, hyposplenia, or post-splenectomy states. Pappenheimer bodies are iron-containing granules, often confirmed with iron stain, and may be seen in sideroblastic processes, splenic dysfunction, or disorders of iron handling. Basophilic stippling appears as multiple small blue granules representing aggregated ribosomal material and can be associated with lead poisoning, thalassemia, sideroblastic anemia, and other disturbed erythropoietic states. Heinz bodies are denatured hemoglobin inclusions, but they usually require supravital staining rather than routine right stain to visualize clearly. The important distinction is that inclusions are not random dots. They are residual structures or damaged cellular components that escaped normal processing. When you see an inclusion, ask what should have happened to it. Should the nucleus have been extruded and cleared? Should iron have been incorporated properly? Should hemoglobin have remained soluble? Those questions reveal the mechanism. Next, we will discuss how a cell's color can indicate marrow activity. Polychromasia refers to red cells that stain slightly blue-gray because they still contain residual RNA. These are young red cells and correlate with reticulocytes. In the setting of anemia, polychromasia is a key functional clue. If hemoglobin is low and the smear shows increased polychromasia, the marrow is responding by releasing young cells. That pattern fits blood loss or hemolysis, assuming the marrow has adequate nutrients and capacity. If hemoglobin is low but polychromasia is absent or minimal, the marrow response is inadequate, suggesting impaired production, nutrient deficiency, marrow suppression, renal erythropoietin deficiency, or chronic disease. This is why respiratory count is so important. Anemia classification should not stop at microcytic, normocytic, or macrocytic. It should ask whether the marrow is appropriately compensating. Polychromasia also reminds us that the peripheral smear is dynamic. It does not just show mature cells, it can reveal how urgently the marrow is trying to correct a problem. For students, this is one of the easiest ways to connect morphology with physiology. And speaking of hemolysis, let's explore its locations. Hemolysis means red cells are being destroyed faster than normal, but the location of destruction matters. Extravascular hemolysis occurs primarily when macrophages in the spleen or liver remove abnormal or antibody-coated red cells. This pattern is common in hereditary spherocytosis and warm autoimmune hemolytic anemia. Intravascular hemolysis occurs when red cells rupture directly within the circulation. This can happen with complement-mediated destruction, severe mechanical injury, some toxins, infections, or transfusion reactions. Both types of hemolysis can produce anemia, jaundice, increased LDH, and reticulocytosis if the marrow is able to respond. However, intravascular hemolysis is more likely to produce hemoglobinemia, hemoglobinuria, and markedly reduced haptoglobin because free hemoglobin is released into plasma. Extravascular hemolysis more often produces splenomegaly and spherocytes, depending on the cause. From a morphology standpoint, spherocytes, schistocytes, polychromasia, nucleated red cells, or bite cells may all point toward hemolytic mechanisms. The main idea is to connect the smear pattern to where and how the red cells are being destroyed. Now, let's put all these pieces together into a workflow for anemia classification. Anemia classification should be approached as a workflow rather than a memorized list. First, confirm that anemia is present by comparing hemoglobin and hematocrit with appropriate reference intervals. Then look at the indices, especially MCV, to classify the anemia as microcytic, normocytic, or macrocytic. Next, assess the respiratory response. This step separates decreased production from increased loss or destruction. After that, interpret the smear morphology in detail. Are there microcytes, macroovulocytes, spherocytes, schistocytes, target cells, inclusions, polychromasia, or nucleated red cells? Finally, choose targeted tests based on the pattern. Iron studies may follow microcytosis. B12 and folate testing may follow megaloblastic features. Hemolysis labs and DAT may follow spherocytes and polychromasia. Coagulation studies may follow bleeding with fragmentation or thrombocytopenia. The workflow prevents overdosing and prevents premature conclusions. For upper-level histotechnology students, this is similar to moving from low-power pattern recognition to high-power cellular detail in tissue sections. You begin broad, then refine interpretation using evidence. Next, we will shift our focus to white cell and platelet production. We are now shifting from red cell morphology into production of white cells and platelets. The reason for pairing these topics is that both require you to recognize orderly development in the bone marrow. When that sequence is disrupted, the marrow may show immaturity, dysplasia, ineffective production, or abnormal cell numbers. This section will focus on practical recognition, how neutrophils mature, how megakaryocytes produce platelets, and how those processes explain findings on peripheral blood smear and CBC. Keep the phrase orderly maturation in mind. Much of hematology interpretation depends on recognizing when that order is preserved and when it is not. We'll start with neutrophil maturation. Neutrophil maturation follows an orderly sequence that begins with the myeloblast and progresses through several stages. Each stage has characteristic nuclear and cytoplasmic features. Early cells have larger nuclei, finer chromatin, and more basophilic cytoplasm. As maturation continues, the nucleus condenses, becomes kidney-shaped, forms a band, and finally segments into lobes. Cytoplasm becomes less basophilic and more filled with neutrophilic granules. This sequence matters because peripheral blood should mostly contain mature segmented neutrophils, with smaller numbers of bands. Earlier precursors in peripheral blood suggest significant marrow stimulation, stress, or a pathologic process. For students, the key is to identify trends. Nucleus condenses and segments, cytoplasm matures and granulates, and the cell becomes functionally prepared for innate immune defense. This orderly process can be disrupted, leading to what we call a left shift. A left shift means that less mature neutrophil forms are appearing in the peripheral blood. Most commonly, this refers to increased bands, but more significant left shifts may include metamyelocytes, myelocytes, or even earlier precursors. The usual reason is increased peripheral demand. During acute bacterial infection, inflammation, tissue injury, or stress, the marrow releases stored mature neutrophils and may also release younger cells if demand exceeds reserve. A mild left shift with clinical infection may be an appropriate response. A marked left shift, especially with very high white count, requires broader evaluation. For laboratory interpretation, describe which forms are present and in what relative amount. Also check whether toxic changes accompany the shift, because toxic granulation and dull bodies support reactive inflammation. The main concept is that peripheral blood can show the pace of marrow response. If demand is high, the marrow may shorten the usual maturation and release timeline. Now, let's shift our focus to platelet production. Megakaryocytes are among the most distinctive cells in bone marrow because they become large, multilobed, polyploid cells dedicated to platelet production. Their maturation involves endomitosis, meaning DNA replication occurs without normal cell division. As a result, the megakaryocyte becomes polyploid with a large multilobated nucleus and abundant cytoplasm. That cytoplasm develops internal membrane systems and platelet territories that will eventually contribute to platelet formation. Mature megakaryocytes extend proplatelet processes into marrow sinusoids, where shear forces and cytoskeletal remodeling help release platelets into circulation. This process explains why platelet production is visually and biologically different from red cell or neutrophil production. One large marrow cell can generate many circulating platelets. It also explains why marrow evaluation is important in thrombocytopenia. The megakaryocyte is therefore not just a cell to identify. It is the production unit behind platelet number and quality. And these platelets, though small, are quite complex. Platelets may look like tiny purple fragments on a smear, but they are highly complex cellular elements. They are anucleate cytoplasmic fragments derived from megakaryocytes, and their function depends on specialized membranes, receptors, granules, and cytoskeletal systems. Platelet membrane receptors allow adhesion to damaged vascular surfaces, especially through interactions involving von Willebrand factor and collagen. Other receptors support aggregation by binding fibrinogen and linking platelets together. Platelet granules contain substances that amplify activation, recruit additional platelets, support coagulation, and participate in vascular repair. When activated, platelets change shape, extend pseudopods, release granule contents, expose procoagulant phospholipid surfaces, and help contract the developing clot. For students, the key is to avoid thinking of platelets as passive plugs. They are active participants that sense injury, communicate chemically, and provide a surface for coagulation reactions. This complexity is critical for platelet adhesion, which starts the clotting process. Primary hemostasis starts with platelet adhesion, a critical first step in forming a plug at the site of vascular injury. Platelets don't normally stick to intact vessels, but exposed collagen and von Willebrand factor create an adhesive surface. Von Willebrand factor acts like a bridge, connecting collagen to platelet receptors, especially GPIB. This initial tethering is vital, particularly in high-flow areas. This receptor-mediated recognition converts vascular injury into a coordinated hemostatic response. Defects in this process can lead to mucocutaneous bleeding, like nosebleeds or easy bruising. Next, we'll see how this initial adhesion amplifies the response. Once platelets adhere, activation amplifies the hemostatic response. Resting platelets are disc-shaped, but when activated, they change shape, becoming spiky and extending pseudopods. This shape change increases their surface area for interactions and exposes active receptors. Activated platelets release contents from their dense granules, like ADP and calcium, which recruit and activate more platelets. They also produce thromboxane A2, further promoting activation and causing vasoconstriction. This activation is a crucial bridge between primary and secondary hemostasis, as activated platelets provide a procoagulant surface for clotting factors. The platelet essentially becomes louder and stickier, sending signals and creating a catalytic surface for clot stabilization. This leads directly into how these activated platelets build the plug. Platelet aggregation is the process where activated platelets bind to each other, forming the primary platelet plug. After activation, the GPIIB/3A receptor on platelets changes, allowing it to bind fibrinogen. Fibrinogen then acts as a bridge, linking adjacent platelets together, creating a growing mass at the injury site. This primary plug is effective for small injuries, but is initially fragile. Later, fibrin will stabilize and reinforce this plug. Clinically, problems with platelet number or function often cause mucocutaneous bleeding because this initial plug is inadequate. Drugs that block GPIIB/3A strongly impair aggregation, highlighting its importance. Aggregation is the teamwork phase of platelet function, where individual activated platelets come together to form a collective plug. Now, let's zoom out and look at hemostasis as a complete system. We've just discussed the detailed steps of platelet function, but hemostasis is much more than just platelets. It's a complex system involving blood vessels, platelets, coagulation factors, regulatory proteins, and fibrinolysis. These components don't act in isolation. They are simultaneous and interconnected. The challenge is to understand what each part contributes to the overall goal: rapid control of bleeding without unwanted thrombosis. We'll explore how these different elements work together to maintain balance. This holistic view helps us understand how the body manages to stop bleeding effectively. Hemostasis is a finely tuned balance between stopping blood loss and preventing unwanted clotting. If the response is too weak, bleeding occurs. If it's too strong or inappropriate, thrombosis develops. The body achieves this balance by localizing clot formation precisely at the site of injury. Intact blood vessels normally prevent clotting, but damage exposes prohemostatic surfaces. Platelets form an initial plug, and coagulation factors generate fibrin for stability. At the same time, natural anticoagulant systems limit the clot to the injured area. Later, Fibrinolysis removes the clot during tissue repair. This balance is why bleeding and thrombosis are two sides of the same coin. Laboratory tests help us understand disturbances in this delicate network. Next, we'll break down the immediate steps of primary hemostasis. Primary hemostasis is the body's immediate, rapid response to vascular injury. It's like an emergency patching crew rushing to a leak. This process is crucial for quickly stopping blood loss, especially in smaller vessels. Vasoconstriction reduces blood flow, giving platelets a chance to act. Platelets then adhere to the damaged vessel wall, activate, and aggregate to form a temporary plug. This initial plug is effective for minor injuries, but it's not very strong on its own. It needs reinforcement to withstand blood pressure. Think of it as the first line of defense, a quick seal before the more robust repair can begin. Next, we'll see how secondary hemostasis provides that crucial reinforcement. Secondary hemostasis builds on the primary platelet plug, stabilizing it with a strong fibrin mesh. This process involves a cascade of coagulation factors that ultimately generate thrombin. Thrombin is the key enzyme here. It converts soluble fibrinogen into insoluble fibrin strands. These fibrin strands then weave through the platelet plug, making it much more durable and resistant to mechanical disruption. Factor 13 then cross-links this fibrin, further strengthening the clot. Defects in secondary hemostasis often lead to deeper, more delayed bleeding, like in hemophilia. So, while primary hemostasis gets the job done quickly, secondary hemostasis ensures the clot is strong enough to last. Now, let's look at how this coagulation process actually gets started. Tissue factor is the primary physiological trigger for coagulation, acting as the injury signal that starts the clotting process. Normally, tissue factor isn't exposed to circulating blood. But when a blood vessel is injured, blood comes into contact with cells that express tissue factor. Factor V then binds to this exposed tissue factor, forming a powerful complex. This complex activates factor X and factor IX, leading to an initial burst of thrombin generation. Even small amounts of thrombin are critical because they amplify the entire clotting process. The prothrombin time, or PT, is especially sensitive to this pathway. It's how the body ensures clotting begins precisely where it's needed. Next, we'll explore how the intrinsic pathway amplifies this initial signal. While tissue factor initiates coagulation, the intrinsic pathway plays a major role in amplifying thrombin generation to ensure a robust clot. Factors IXA and VIA come together on the surface of activated platelets, forming what we call the intrinsic tenase complex. This complex efficiently activates factor X, leading to a significant burst of thrombin. This burst is essential for producing enough fibrin to create a stable clot. Deficiencies in factor 8 or factor 9 cause hemophilia A and B, respectively, highlighting the importance of this amplification step. Activated platelets are crucial here. They provide the necessary surface for these coagulation complexes to assemble. This shows us that platelets and coagulation factors work together, not in isolation. Now, let's move to the final common pathway where fibrin is actually made. The common pathway is where all the coagulation pathways converge to produce fibrin, the essential component of a stable clot. It begins when factor X becomes activated. Factor XA, along with its cofactor factor VA, calcium, and a phospholipid surface, converts prothrombin into thrombin. Thrombin then performs its critical role. It converts soluble fibrinogen into insoluble fibrin monomers. These fibrin monomers polymerize into strands, and factor 13 then cross-links these strands, making the clot strong and durable. Because this pathway is shared, deficiencies in factors X, V, 2, or fibrinogen can prolong both the PT and APTT. This pathway is also the target for many anticoagulant medications. Ultimately, all roads in coagulation lead to the common pathway, ensuring enough fibrin is made to stabilize the initial platelet plug. We have just discussed how the common pathway makes fibrin. Now, we need to consider how the body prevents that clotting from spreading uncontrollably. Natural anticoagulant systems are crucial for keeping clots localized to the site of injury. Antithrombin, for example, inhibits thrombin and factor XA, and its activity is boosted by heparin-like molecules. Protein C and protein S work together to turn off factors VA and VIA, which reduces further thrombin generation. These systems ensure that hemostasis is strong where it is needed, but quiet everywhere else. If these natural anticoagulants are deficient, the risk of thrombosis goes up. This localization is key to preventing widespread clotting. Once a clot has done its job, the body needs a way to remove it. That is where fibrinolysis comes in. This process removes fibrin clots after they have served their purpose, allowing for tissue repair. Plasmin is the central enzyme here. It digests fibrin into degradation products. Tissue plasminogen activator, or TPA, helps convert plasminogen into plasmin on the fibrin surface. When cross-linked fibrin breaks down, D-dimer is released, which is why D-dimer testing tells us that clot formation and breakdown have occurred. Fibrinolysis is tightly regulated to prevent premature clot loss. It is the cleanup and remodeling phase of hemostasis, ensuring the system can return to normal. We have covered how clots form and how they are removed. Now, let's connect these processes to what you might see in a patient. Different bleeding patterns can actually suggest which part of the hemostatic system is impaired. Platelet problems, whether in number or function, often cause mucocutaneous bleeding. Think petechiae, easy bruising, nosebleeds, or heavy menstrual bleeding. On the other hand, coagulation factor problems typically lead to deeper bleeding, like hemarthrosis or muscle hematomas. Of course, some disorders can blur these lines. A careful patient history is vital here. It helps guide which laboratory tests we should select. The pattern of bleeding is a powerful clue. We have explored the intricate balance of hemostasis, from initial injury response to clot removal. Now, we shift our focus to how we actually evaluate this system in the laboratory. This section will cover the practical aspects of hemostasis testing. We will look at specimen handling, common screening tests, and how specialized assays help us understand platelet function, factor deficiencies, and fibrinolysis. The goal is to understand what each test is trying to tell us and what its limitations are. This is where the rubber meets the road, translating physiology into clinical evidence. Before we even run a test, specimen quality is paramount in hemostasis. Many coagulation tests need citrate plasma, usually collected in a light blue top tube. The ratio of blood to anticoagulant must be precise. If a tube is underfilled, too much citrate can falsely prolong clotting times. Patients with very high hematocrit might also need citrate adjustment because their plasma volume is reduced. We must mix specimens gently and process them quickly to avoid clotting or factor degradation. Hemolysis, lipemia, or prolonged storage can interfere with results. Always ask if the specimen was handled correctly before interpreting an abnormal result. This is foundational for accurate interpretation. A platelet count is often the first piece of hemostasis information we get, but it's really just the beginning. Thrombocytopenia, or a low platelet count, does increase bleeding risk, especially when it's severe. But the clinical impact depends on many factors, like the cause, how fast the count dropped, and if the platelets themselves are working right. On a smear, if you see large platelets, that might suggest the marrow is working hard, releasing younger platelets to replace ones being destroyed. And watch out for platelet clumping. That can falsely lower automated counts, so always check the smear. A normal platelet count doesn't guarantee normal primary hemostasis. Medications like aspirin, inherited defects, or even conditions like uremia can cause platelet dysfunction. So, smear review and clinical history are crucial companions to the CBC. In histotechnology, remember that number and structure aren't enough. Function truly matters. Even with enough platelets, if they can't adhere or aggregate, bleeding can still happen. Now, let's look at how we test that function. Platelet function testing goes beyond just counting platelets. It asks how they actually behave. These tests evaluate different aspects of platelet physiology, including adhesion, activation, secretion, and aggregation. Light transmission aggregometry is a classic method where we watch how platelet-rich plasma clears as platelets clump together in response to different activators. PFA-type systems, on the other hand, assess how well platelets form a plug under conditions that mimic blood flow. But here's the challenge. platelet function tests are very sensitive to pre-analytical factors. Things like recent aspirin use, other antiplatelet drugs, even herbal supplements, or issues with specimen handling can all affect the results. So we choose these tests based on a clear clinical question. Are we looking for an inherited disorder, a drug effect, or von Willebrand disease? Platelet function testing is most useful when we align the patient's physiology, their history, and the quality of our specimen. Now we'll move on to the coagulation cascade, starting with the PT test. The prothrombin time, or PT, is a key screening test that evaluates the tissue factor pathway, also known as the extrinsic pathway and the common pathway. It's particularly sensitive to factor 7 because that factor has a relatively short half-life. We often report PT results with the INR, or International Normalized Ratio, which helps standardize warfarin monitoring across different labs. A prolonged PT can indicate several issues: warfarin therapy, vitamin K deficiency, liver disease, or deficiencies in common pathway factors like X, V, 2, or fibrinogen. Always consider the patient's medication history. Warfarin, for example, directly affects vitamin K-dependent factors. Liver disease can prolong PT because the liver produces many clotting factors. But remember, PT doesn't measure the entire hemostatic system, and a prolonged PT doesn't always predict bleeding severity. For you, think of PT as a window into the tissue factor-driven clotting and the final common pathway of fibrin formation. Next, we'll discuss the APTT, which looks at a different part of the coagulation system. Building on our discussion of the PT, the activated partial thromboplastin time, or APTT, is another clot-based screening test. This one evaluates the intrinsic and common pathway factors. It's affected by factors 12, 11, 9, 8, X, V, 2, and fibrinogen. We commonly use it to monitor unfractionated heparin therapy, though anti-XA assays are also important. A prolonged APTT can be due to factor deficiencies, heparin, a lupus anticoagulant, or other specific inhibitors. If an APTT is prolonged, a mixing study is often the next step. We mix the patient's plasma with normal plasma. If the APTT corrects, it suggests a factor deficiency. If it doesn't correct, we suspect an inhibitor. But interpretation can be tricky. For instance, factor 12 deficiency can significantly prolong APTT but usually doesn't cause bleeding. Lupus anticoagulants also prolong APTT but are more linked to thrombosis than bleeding, so context is crucial. Now, let's look at fibrinogen, a critical substrate for clot formation. Fibrinogen is the soluble protein in plasma that gets converted into fibrin, the meshwork that stabilizes a clot. So, measuring it helps us assess the raw material needed for clot formation. The Class fibrinogen assay estimates its functional activity. Low fibrinogen levels can occur in conditions like disseminated intravascular coagulation, severe liver disease, or massive bleeding. Dysfibrinogenemia is different. The protein is present, but its function is abnormal. In those cases, comparing functional and antigenic fibrinogen can be very informative. Fibrinogen is also an acute phase reactant, meaning its levels can rise with inflammation, pregnancy, or malignancy. This means a normal fibrinogen level doesn't always rule out consumption if the patient has an underlying inflammatory condition. In DIC, trending results over time are often more useful than a single value. For you, remember that clotting needs both active enzymes and enough substrate. Without functional fibrinogen, even with thrombin, a stable fibrin clot can't form. Next, we'll discuss D-dimer, which tells us about fibrin turnover. We just discussed fibrinogen, the substrate for clot formation. Now, let's talk about D-dimer, which tells us when that fibrin has been broken down. D-dimer is a product of cross-linked fibrin degradation, so it indicates that both clot formation and clot breakdown have occurred. A negative D-dimer can be very useful for ruling out venous thromboembolism in low-risk patients. But remember, an elevated D-dimer is not specific for a clot. It can be high in many conditions like inflammation, trauma, or pregnancy. So, we always interpret D-dimer results with the patient's clinical probability in mind. It's a sign of fibrin turnover, not a diagnosis in itself. This test really highlights the dynamic nature of hemostasis, showing us the cleanup phase after a clot has formed. Next, we'll look at how we investigate prolonged screening tests. After discussing D-dimer and its role in fibrinolysis, let's move to a classic diagnostic tool, mixing studies. When a PT or APTT is prolonged, mixing studies help us figure out if it's a factor deficiency or an inhibitor. The principle is straightforward. We mix the patient's plasma with normal plasma, which contains all the clotting factors. If the prolonged time corrects, it means the normal plasma supplied the missing factor, pointing to a deficiency. If it doesn't correct, we suspect an inhibitor is present, interfering with the clotting process. Some inhibitors are time-dependent, so we might do both immediate and incubated mixes. This is a functional test, an experiment in the lab, that helps us narrow down the cause of an abnormal screening result. This leads us directly to how we pinpoint the exact factor involved. Building on mixing studies, which tell us if a deficiency or inhibitor is present, factor assays pinpoint the exact defect. These tests measure the functional activity of individual coagulation factors. We order them when screening tests are abnormal, or if there's a strong clinical suspicion of a specific factor problem. The patterns of factor deficiencies can help us distinguish between inherited conditions like hemophilia, broader issues like liver disease or vitamin K deficiency, and the presence of inhibitors. The results of these assays are crucial for guiding treatment, whether it's factor replacement or other targeted therapies. So, factor assays take us from a general pathway problem to a very specific molecular diagnosis. Now, let's consider a common bleeding disorder that often requires a panel of tests. Following our discussion on specific factor assays, we need to address von Willebrand factor, which is unique because it bridges primary and secondary hemostasis. Von Willebrand factor is essential for platelet adhesion and also carries and stabilizes factor VIII. Because of its dual role, testing for von Willebrand disease often requires a panel, not just one test. This panel typically includes VWF antigen to measure the amount, activity assays to assess its function, and factor VIII activity. Sometimes, multimer analysis helps us subtype the disease. Interpretation can be tricky because VWF levels can fluctuate with stress, inflammation, and even blood type. This is a great example of how a single protein can impact multiple parts of the hemostatic system. Next, we'll look at a complex condition where the entire hemostatic system goes awry. We've explored individual components of hemostasis, but now let's look at a condition where the entire system becomes dysregulated, disseminated intravascular coagulation, or DIC. DIC isn't a disease itself. It's a complication of severe underlying illnesses like sepsis or trauma. In DIC, coagulation activates throughout the body, consuming platelets and factors, and forming fibrin in the microvasculature. This leads to a dangerous paradox. Patients can bleed and clot at the same time. Lab findings often include low platelets, prolonged PT and APTT, low fibrinogen, and elevated D-dimer, sometimes with schistocytes on the smear. Trends in these results are often more informative than a single measurement. DIC is a stark reminder that hemostasis is a finely balanced system, and when that balance is lost globally, it can have devastating consequences. Next, we'll discuss how common medications can complicate our interpretation of these tests. Anticoagulant medications are a major factor in interpreting hemostasis tests. These drugs are designed to alter clotting, so they will affect our assays. We need to know what medications a patient is taking to properly interpret their results. Different anticoagulants affect different tests in different ways. This means a prolonged PT or APTT might be therapeutic, not pathologic. Always consider medication history when reviewing unexpected results. This is a practical lesson for the lab. Results are shaped by therapy and methodology. Now, let's apply our knowledge to some case patterns. Let's apply our workflow to a microcytic anemia pattern. A patient has low hemoglobin and a low MCV. The first thought might be iron deficiency, but we need to think about all the mechanisms that cause microcytosis. Iron deficiency limits hemoglobin synthesis. Thalassemia limits globin chain synthesis. Chronic inflammation restricts iron availability. The RDW and RBC count help us refine the pattern. Iron deficiency often has an increased RDW. Thalassemia trait may have a very low MCV with a relatively preserved RBC count. The smear adds visual detail like hypochromia or target cells. Iron studies and patient history then guide confirmation. Microcytosis is a clue, not a diagnosis. Next, we'll look at a bleeding pattern. Now, consider a patient with easy bruising, petechiae, nosebleeds, and heavy menstrual bleeding. This mucocutaneous bleeding pattern suggests a primary hemostasis problem. Our first lab step is the CBC and smear. Is the platelet count low? Are there platelet clumps? If the platelet count is normal, platelet function becomes the question. Medication history is crucial here. Von Willebrand disease must also be considered. Testing may include PT, APTT, platelet function screening, and VWF assays. Let the bleeding pattern guide your workup. Don't jump to rare factor assays if a common platelet problem is more likely. Now, let's look at a prolonged APTT. A prolonged APTT is a common lab finding, and context is key. First, always check for anticoagulant exposure. Heparin, direct thrombin inhibitors, and some factor XA inhibitors can prolong APTT. If medication isn't the cause, a mixing study is the next step. Correction with normal plasma suggests a factor deficiency. No correction suggests an inhibitor. Factor 8, 9, and 11 deficiencies can cause bleeding. Factor 12 deficiency prolongs APTT but usually doesn't cause bleeding. Lupus anticoagulants prolong APTT but are linked to thrombosis, not bleeding. Always start with the patient's clinical picture. Next, we'll examine low platelets. Thrombocytopenia needs confirmation with a smear review. Platelet clumping can cause falsely low automated counts. Once confirmed, think mechanistically. Is the marrow producing too few platelets? Are they being destroyed, consumed, or sequestered? The smear gives clues: giant platelets, schistocytes, or blasts. Clinical context is vital: infection, medications, autoimmune disease, or malignancy. Urgency depends on the count, bleeding, and associated findings. The platelet count is the headline, but the smear and patient context tell the full story. We'll now discuss building good correlation habits. The strongest habit you can build in hematology is correlation. It's about connecting all the pieces of information you have. If the analyzer flags a low MCV, you should look for microcytosis and hypochromia on the smear. If the RDW is high, look for anisocytosis. If the platelet count is low, check for clumps or giant platelets. Use physiology to explain results. Don't just memorize associations. If something is unexpected, treat it as a question to investigate. Is it artifact, a specimen error, a medication effect, or a true pathologic pattern? And remember, clear communication of significant abnormalities is crucial in the lab. These habits align with the broader laboratory mindset: quality first, careful observation, disciplined interpretation, and clear communication. Hematology rewards those who can connect small visual details to larger biological processes. As we approach the end, let's talk about common pitfalls to avoid. First, never diagnose from just one cell or one test. A single target cell or a prolonged APTT is a clue, not a complete answer. Second, always consider pre-analytic variables. A clotted specimen, an underfilled tube, or delayed processing can create misleading results. Third, don't separate the platelet and coagulation systems too rigidly. They interact constantly. Platelets provide surfaces for coagulation. Thrombin activates platelets, and fibrin stabilizes the plug. Fourth, always consider medication effects. Antiplatelet drugs, anticoagulants, and other medications can all influence hematology and hemostasis results. Finally, avoid memorizing patterns without understanding the mechanisms. If you understand why iron deficiency causes hypochromic microcytes, you can reason through unfamiliar cases. Pitfalls are reduced when your interpretation is systematic, mechanism-based, and acknowledges uncertainty. The most important takeaways from this lecture are conceptual. First, morphology reflects cell production, structure, and survival. Red cell size, color, shape, inclusions, and polychromasia all point toward underlying processes. Second, platelet biology connects vascular injury to coagulation. Platelets adhere, activate, secrete, aggregate, and provide procoagulant surfaces. Third, hemostasis is not just clot formation, it's regulated localization of clot formation followed by controlled clot removal. Bleeding and thrombosis represent failures of this balance. Fourth, laboratory interpretation requires quality, context, and correlation. A result is only as reliable as the specimen and method, and it only becomes meaningful when interpreted with clinical information and related tests. For HTL 308, you should be able to describe what you see, explain why it happens, and connect it to a rational next step. That's the difference between recognition and understanding. To close, let's bring it back to 3 key habits. First, describe clearly. Name the morphology or laboratory abnormality accurately before jumping to interpretation. Second, reason mechanistically. Ask what process could create that finding. Is it impaired hemoglobin synthesis, DNA maturation delay, membrane loss, fragmentation, platelet dysfunction, factor deficiency, inhibitor activity, or excessive fibrinolysis? Third, correlate responsibly. Compare the smear with the CBC, the screening test with the clinical history, and the abnormal result with specimen quality and medications. Hematology can feel dense because it includes cells, plasma proteins, vessels, instruments, and clinical syndromes. But the same logic repeats throughout the field. Structure reflects function, and abnormal results reflect altered biology. If you can explain that biology in plain language, you're well prepared for advanced coursework and laboratory practice. Thank you for your attention. In discussion or review, focus on walking through patterns step by step rather than trying to memorize every isolated detail at once.